afternoon, everyone.
How are you?
Good. My name is Michaela Hickey, and I am pleased to welcome you to What's Up Doc, a monthly lecture program brought to you by the Concord Hospital Trust. Concord Hospital Trust would like to recognize and thank the Walker Lecture Series for their generous sponsorship of What's Up Doc. The Walker Lecture Series offers a wide variety of programs on history, art, and science, as well as dramatic, musical, and literary performances. All events are free to the public and held at the Concord City Auditorium. We encourage you to check out their website at walkerlectures.org to view their calendar of programs. What's Up Doc is proud to welcome Dr. Vaida. Dr. Vaida's topic today is what's new in cardiothoracic surgery. Dr. Vaida joined Concord Hospital in 2019. Following medical school, Dr. Vaida completed his residency at the Virginia Commonwealth University School of Medicine, Medical College of Virginia in Richmond, Virginia, and then he went on to complete a fellowship in cardiothoracic surgery at Ohio State University Medical Center in Columbus, Ohio. Dr. Vaida is board certified in general surgery as well as thoracic and cardiac surgery. Please join me in welcoming Dr. Vaida.
Thank you. Thank you. Thanks, Michaela. Thanks, everybody. Good afternoon.
Good afternoon.
Good afternoon. Enjoy your lunch. Thanks for having me. It's a pleasure. It's my at least second time I look back. I was last year in April of last year. So Ms. Pulley asked me to give you guys a quick update as to what's new, what's been happening in our cardiothoracic surgery department here at the hospital. And I'm very happy to, I looked at my slides from last time, and initially I wanted to do completely new slides and such, but then I realized that what I might want to do is use some of the old slides and give you almost like a board report, like what happened new since, did we achieve some of the things that on the previous slides were future goals or not, and a few things like the new things that we're looking at, because I feel that we should always look towards the future. I feel that this is a great organization where we're small enough yet big enough to still be able to be like a speedboat and adjust with the times and move on. Not to bring it back, but I feel that when COVID, I think this organization weathered the COVID storm very well. I feel that. We were obviously in the front line, but looking at how the administration dealt with it, how the staff and all that, I think that we did great. I still have contacts with other big organizations in Ohio and Virginia and so forth, and I know their challenges, so I feel that comparing we did very well. So, cardiothoracic surgery department, it's three of us. I'm doing the general thoracic side of things, lung cancer, lung benign disease, esophageal work, airways, things of that nature. And I have two partners who are open heart surgeons, and they do the open heart surgery part of this, coronary bypass, aortic valves, aortic work, and so forth. And actually, might not be a bad idea to have, I'll talk to them and with Ms. Pulley, maybe to have one of them do a little spiel about the open heart part, because it's a very vigorous part of our practice. They're very busy with open heart. We also have a very busy and very robust structural heart program. So it sounds very fancy. We like these fancy names like the Cardiovascular Institute and so forth. But basically what it means is that it's a department where the open heart surgeons work closely with cardiologists and radiologists, people from radiology, and they come together with a good plan for certain patients to have aortic valve replacement, replacement of aortic valve, done through catheters through the groin versus big operations in the middle of the splitting the sternum. It's called TAVR, transcatheter aortic valve replacement, and it's a very good program. It's very busy with very good results. So it's been going on for a few years now. So that's kind of from the open heart part of the practice. Again, I think that we should be good to have one of them, and I'll talk to them to have and talk to you guys about open heart.
Dr. Vaida, I don't think you may even be aware of this yet, but Concord Hospital's heart was named a great heart program.
There we go.
The only program in New Hampshire and one of 100 programs in the United States by Becker's Healthcare. Yesterday, we just found it out.
Oh.
We're very proud.
There you go. Excellent. So yes, I knew there was good. So there isn't more to have somebody chat more about that with a cardiologist. So on the general thoracic part, the as I said, lung and non-open heart, I think that the main progress that we had since last visit and over the last few years is now we were able to start a very robust robotic thoracic surgical program, meaning that in the past, big surgeries, removing lung cancers or other, procedures in the chest were done with either bigger incisions or small incisions, but like sort of the same instruments that were used for abdominal surgery. Now we do have the robot, and we can do the same procedures with very small incisions, faster recovery time, less pain. Patients go home obviously faster, they feel better, they go back to society sooner. And some of from a clinical point of view, the results of the procedure are better. You can get a better dissection in terms of removing lymph nodes, and a better result if you do this for lung cancers. I think at this point in time we have over 100 procedures that we did here robotically. We do everything from removing tumors from behind your breastbone, from lung cancers, fixing hernias in the diaphragm and so forth. So any work in the chest that in the past was done either with open incisions, bigger incisions, or with VATS, video assisted thoracic surgery, can be done now with a robot, and it's a great tool. So this is under the category of things that moved on and with good success since last meeting, last WhatsApp doc. This is a picture I took, this is in our OR, this is our robot, in one of our cases. As you can see, the patient is down there, laying down there and it looks like it's attacked by an alien. It is overwhelming. It is overwhelming. I can see why not. I can see why it wouldn't be. But it's all controlled. It's all under control. This is one of our physician assistant. We're waiting for. We remove portions of the lung lesions, and we send it to pathology. And we're waiting for results from pathology, whether it's a cancer or not, to see where they're moving on. So this is when I took this picture while we're waiting on results from pathology. But as I said, I think we have at least a little bit over 100 procedures so far. And it's moving, it's going well. And it's great because we can offer procedures like this here versus patients need to go to Dartmouth or Boston or anywhere else. So that's great. You can stop me if you, at any point in time, have questions and something that, go ahead.
Where were you?
Very good question. Very good question. Well, I was the one taking the picture, but there's a console, so literally, so the patient is here like this, anesthesiologist is back there behind the blood-brain barrier, we call it, and there's a console literally here, and this will be sitting at a console with a head on the console, and it's not a 3D vision, but it's like a stereotactic vision of the field. So I will be literally sitting here at the console. So you are a few feet away from the patient. Your head is sort of like a little bit of a console there. There are microphones and speakers there. So I talked to the rest of the crew. There's microphones and speakers up here in this boom, so they can talk to me through it and so forth. So, and usually when we're working, the lights are down, they're dimmed in a room. This is a setup, a pause when we're waiting for specimens to be processed. So if I have to scrub out, obviously I am a few feet away, but yes, I am away from and I'll get to, the main difference and the main sort of, is that you can obviously, as a surgeon, you get no feedback, you get no tactile feedback from what you're doing in the chest. So over time, you end up learning how to kind of, they call it feel with your eyes. You're gonna look at the tissue, you have the instruments in there that you are manipulating the tissue, the lung or whatever tissue you're working with, and you kind of get the visual feedback from the tissue, but you cannot feel anything. And that's a part, the steep part of the learning curve. in this kind of procedure, because everything else you kind of get your hand is either in the tissue on the specimen there directly, or even when you do a video assisted thoracic surgery, your hands are the ones manipulating the instrument, so you get some feedback. But in this you cannot. But the advantage is that you have a camera that's inside, so there are 4 arms of the robot. You have instruments through arm 1, 2. Arm number 3 is a camera aiming in the chest. Arm number 4 is another instrument. So you have 2 working hands. You'll be your left hand here, right hand here, working the instruments, camera in the middle, and you have a second sort of left hand, if you would, that you, with a clutch pedal, you toggle between between arm 1 and arm number 2. So you use this for retraction, and then the active arms will be arm number 2 and 4 in terms of instruments. So again, the machine is moving the instruments, and you're giving just the commands remotely from the console, so you cannot feel. So that's but the camera, as I said, it's a high definition camera. It's right there where you're working. So it's as if you do an open surgery, but with much smaller incisions, and your eyes are like right there in the chest versus where you usually stand and work. So, sorry, you had a question.
Yeah, I just wondered, how many people are in the OR when you do that?
Very good question. So it's near the console, 1 physician assistant. There's a scrub tech who usually sits kind of over here with instruments, and we have a circulator, a nurse who's not scrubbed, and on the anesthesia side, there's only at least 1 person, either anesthesiologist or CRNA. So it doesn't. It's the same team, so it doesn't. This machine does not involve more manpower. It's the same team. It's a specialized team. Myself. So let's see. I'm sorry. So this will be the layout. So you have the operating room there, the operating table there with a robot, and the console where the surgeon basically sits away from the table. And I guess this would be the anesthesiologist here, and this would be the assistant by the table. So, go ahead, John.
You mentioned using eyes instead of tactile.
Correct.
I assume that people are hard at work at providing the tactile feedback.
It's most likely, probably. I can't see how. So this robot has been around. So to be a little background, initially the robot was developed a few good years back, well maybe 10, 15 years back, for 2 indications. One was, and still is very active, is prostate surgery for urologists. It works very well for that specific operation. And 2, it was developed for cardiac surgeons, for open heart surgeons, to harvest one of the blood vessels that we use from inside the chest for coronary bypass for grafting. Well, it so happens that the cardiac surgeons kind of didn't like that part. They didn't take on with the cardiac surgeons. The urologists loved it and ran with it. And then it was adapted for general surgery, for OBGYN, urology, for other procedures in urology, not only prostate surgery, and then thoracic surgery. They went through various variants, various generations of the robot, and the most recent one is the one that it allows, basically, there's a wrist articulation inside the chest. Basically, the instrument now, they're so good that basically you slide them in the chest, and literally it's as if they have a wrist in there in the chest. It moves literally kind of like it has the natural movement of a human wrist when it comes to instruments. So the other advantage of this latest generation robot is that it allows stapling inside the chest with a robot. Prior to this generation, which was the robot that we had here when I got here, and I sort of advocated to get the newer one. Prior to this, you could not use the robot itself to staple. You had to have one of the assistants slide a stapling device in the chest or the abdomen, wherever you work, and had that person staple it. So this is much better because as a surgeon, you're in control of what the dissection, what you did, and how you did it, and you know what kind of staple to use and how to use it and so forth. So it takes a lot of the not as much pressure, but responsibility from the staff, and it puts in your court, and it's a much better process, if you would. So if they're working on it, maybe, probably, possibly, I'm not sure how they would do it, but they're smart people in California, Sunnyvale.
How many of these do we have, and how much do they cost?
Right. We have only one, and we have only one, and they're $1 million each, I think, and then it's just a matter of, then it goes to the C-suite, and you look at, how many cases, consumables, and what other, how other surgeons are doing, and so forth. So it's, yeah. Do we get time on a robot? Yes. I mean, whenever we need to do a patient on a robot case, you have to call and make sure you get some time. Would it be good to have another one? Maybe, possibly, yes. What I've seen, and it's interesting now we're discussing this, the community is getting larger.
House-wide and ED, code white. House-wide.
That's why we're blue, not white. I'm saying. So what I've heard, and I know it happened, it's a smart move, I feel. One of the hospitals down, I don't know, Nashville, or they have a robot in an ambulatory, like in a day surgery setting. So you can come in and have hernias and other procedures that you don't have to be hospitalized. You don't have to stay in house over. You get admitted for observation for 10 hours and whatnot, and you go home. And I think that's a smart move. So, but it's okay. So here it's our department at thoracic surgery. Urology obviously is very involved. It's a large group in urology. General surgery, and OBGYN. So we're the ones fighting for robot time. Pam?
So I'm just curious, because I know Dr. Benson's here, and he was the first surgeon in, I believe, in our community that used laparoscopic laser surgery, which was a little bit similar in terms of you really couldn't see, right, Dr. Benson? And so how is this different, or how is this the same?
I don't know, what was it? Was it laparoscopic surgery or urology or?
Well, we started the laparoscopic program here in 1990 with gallbladders, and then moved on to hernias and appendices and colons and hiatal hernias and so forth. And then, like you, I had boards in general and thoracic and cardiac. We didn't have a cardiac program at that time.
Right.
But we started the VATS program here.
Okay.
In fact, we did the first lobectomy for cancer done in New England here at this hospital by a VATS approach.
Oh, good.
So we were told later on by the people from the company that provided the materials that so we have a history there.
There we go. So we're trying to stay on the tracks, right?
Well, she talked about laser. I'll tell you a quick story. When we started doing gallbladder surgery, we went down to Eddie Reddick's program down in Nashville to learn how to do it, and he was tied in with the laser company. So he wanted to make sure that everybody used a $500 fiber to take the gallbladder out from the bed and the liver. Well, what happened was, as soon as we got back here, we realized we don't need laser. We don't need a cautery unit of $35 worked just fine.
Correct, right.
So we decided that laser, which it's an acronym, it stands for light amplification by stimulated emitted radiation. We always thought it stood for latest attempt to secure extra revenue.
True. That's good, yeah. There are some players out there in the industry who would try to push, then every few years, I guess, or every generation, whatnot, there's some gimmick that is being pushed and is sold as the next, the new sliced bread, and this will be the best. But as you know, and you know, that things kind of, settle and they get weeded out, but you're right, for laparoscopic gallbladder resection, a bovie is all that you need. But, now they have harmonic scalpels and harmonic this and so forth, well, we use the staplers, invented, in actually what I call Soviet Union many years back, but they work very well. So any other questions about the robot? I can talk for hours about it. Go ahead.
Are there certain patients that do better with robotic
Right.
versus human?
Very good question. Actually, we have a patient in a hospital today that had surgery 2 days ago. He's a gentleman who unfortunately was found to have a lung nodule, actually August of last year. I just met him 3 weeks ago, and looking at CAT scan, I said, this is most likely lung cancer. Best is to get it out. That's why I told all my patients that the only way to cure lung cancer, or at least lung cancer, is to remove it. Everything else, can help, can mitigate, can shrink, the issue with him is that his lung function, he's 67, but he smoked, he has a 51-pack-year history of smoking. He's been smoking for many years. Quit recently, about 2 or 3 years ago, but the damage is already done. So his lung function is terrible. So DLCO is 30%, so you would know what that means. Very, very, very poor. So his lung capacity of exchanging CO2 for oxygen is only at 30%, which is, it's low. I mean, we want to see it 60 and above to go ahead and do surgery on them, safely. So, I propose surgery to him, robotic surgery, just not removing the entire lobe, just removing just the lesion and a good margin and lymph nodes. And it's also very good because the robot allows us to remove lymph nodes to stage the lung cancer very well, much better than a VATS, or equally, if not same as an open procedure. But the advantage of this is that it took us from skin to skin probably an hour and a half. So the exposure to general anesthesia, to you only have to breathe with one lung while we're doing this and so forth, was very short. Mainly it's the anesthesia exposure that, the fact that you have to be on one lung ventilation for as long as it takes to work on that. So those would be patients that prior to this, probably nobody would have offered them surgery. It would have been radiation or chemotherapy, but now they have an advantage of having this done. So there are. And in general, it works like even on let's say, a patient with good physiological status, and you'd rather have surgery done with the small incisions and only 2 versus a big incision, or even with a VAT. So I thought even with the VATS, patients, even if you have like only 3 incisions in the VATS or whatnot, they would stay in the hospital longer. The pain they have more pain than with this, so it's better.
Thank you.
All right. So as I said, I can talk about this robot for a while, but moving on, lasers, photodynamic therapy. It's something that I talked to you guys about last time. Basically. Update, I did see a patient just this past week in clinic who will benefit from this. Basically what it is, it's laser therapy for endobronchial lesion cancers inside the airway. The advantage of photodynamic therapy is that the patient gets injected with a substance called photofrin that gets concentrated in the tumor itself, and then when you put this light fiber with a laser fiber in, this tumor gets sensitized to a specific wavelength of this laser. So you are able to target just the cancer versus other sort of like much lasers with scattered and things like that. This is a much targeted therapy. Patient goes to the operating room and has a bronchoscopy. You'll see this is. You ask me how many people in the OR. Way too many people in this procedure here. Usually it's just me, the anesthesiologist, and me, and probably a physician assistant. And you get all the way to where the tumor is. This is a tumor inside the airway, and you put this light fiber in it. You turn the laser on, and basically it burns the tumor, but it burns just the tumor, and the penetration outside of the tumor is it's 1 or 2 millimeters. So there's very little to no damage to otherwise the lumen, the wall of the airway. To my knowledge, we're the only center definitely New Hampshire who offers this. Other than that, it's going to be Boston. It's a technique basically that is now, it has been part of the NCCN guidelines for treatment of lung cancer. The NCCN guidelines are the National Committee for Cancer Network, something like that looks at basically establishes the guidelines for treatment for all cancers, whether it's lung or colon or whatnot. And photodynamic therapy is part of the recommended therapies for lesions. We can use it for lung and esophageal to open up the esophagus for patients that have a large tumor that they cannot swallow. And it is in here part of the, I know this word multidisciplinary it's very fancy, but truly here it does work as a multidisciplinary because I do not know where these patients are. They have to be sent to me by pulmonary medicine doctors or by the medical oncologist. So it's truly a multidisciplinary approach. It's when, in this patient that we're going to work on this next week, was sent to me by Dr. Black. He just saw him in June in the hospital as a gentleman who came in with a 6 months history of coughing up blood and not feeling well, who needs some help. So, questions? Go ahead.
Does it make any difference how large the tumor is in the esophagus?
No, not really. What you want to do is no. Short answer is no, it doesn't, no.
Well, I'm just curious because I know a gentleman that had esophageal cancer. This was a long time ago, and he had to have surgery and reconstruction.
Yeah.
So this would be
Yeah.
so wonderful.
Well, this is meant to, two indications for instance, to go too much into detail. One is the more common one is what we call palliation. Patients who have a large tumor in the esophagus, they cannot swallow, they cannot eat, they cannot drink. So you do this treatment, you open up their esophagus, then you can complement it with a stent. I'll talk to them about that in a little bit. And you give them back the pleasure of eating and nutrition and so forth while they're doing some treatments, to try to keep it at bay. And sometimes you do that in preparation for surgery, try to downstage to shrink the tumor, improve their nutritional status, give them a better chance to tolerate a big operation. As I'm sure you know, these operations on esophageal cancer are big procedures. They take a huge toll on the patient. It's a big enterprise. It's a long haul. So whatever we can do to prepare them better for it, and this will be part of it. And in some patients, it's just there's nothing else that you can do, and I feel that it's important. In the past, you would give them feeding tubes or things of that nature. I feel that if you can offer them, the option, the possibility to continue to eat from above, to eat and enjoy food and drink liquids and whatnot, that's important in terms of quality of life.
Could you use it in stomach cancer also?
You could, yeah. You could. It's better to be used in sort of like if you would confined spaces like this. Like this is a picture of a cancer inside of an airway. So you can basically put the fiber in there and sort of like have it in that space there. Otherwise, the light will like scatter, if you would, in a cavity like a stomach. So.
That was actually my question. I think you answered it. Is it palliative or curative? Or both?
It's both. The majority of cases are palliative. There are instances it can be used for a very early. I had a case when I was at Ohio State where a patient had a very small tumor inside an airway, like a small tumor that was found on a wall of an airway. So we did photodynamic therapy. That tumor, then we went back and did biopsies, proved that it's gone. It was treated. It went away, and then we were able to do a bigger procedure, the next step surgery for a different cancer, for down away in the lobe. So it's both. The majority of cases, though, it's palliative, but for both. The other thing that I talked about last time when I was here, April of last year, was navigational bronchoscopy. Again, fancy term. With a bronchoscope, so through the airway, and using a special machine through which you can plot a trajectory all the way from the mouth into the airway into the lung to where a lesion is. Let's say the patient has a lesion in a lung, like it's down there on this CAT scan, and you would like to go all the way into the airway, through the lung, all the way to where this lesion is, and take a biopsy from it to see whether it's a cancer or not. And the way this works is that you get a CAT scan of the chest, and you use a special, it's a computer laptop that has a special software that generates an airway, a tree, a bronchial, an airway tree, and then the software will map basically a trajectory, kind of like a breadcrumb, kind of like the GPS on your car when you want to go to whatever destination, and you will follow that line into the lung, into the airway, all down to where the lesion is to try to get a biopsy of it. We have this technique here. It's been around for a few years. We're using it here, myself and the pulmonary team. But as we're moving forward, the next system is, again, it's a robotic. So it does the same thing as this, but it basically takes away this part where instead of having your hands in a human pushing this bronchoscope in and moving it in and looking at a monitor as to how to get it in all the way to where the lesion is, you have a console and a robotic arm that actually moves this probe inside the patient's airway and then down into the chest. What you do, you're standing at this console here, and literally there's two spheres, two balls, and with one you move forward and the other one you move left and right, and you are guiding with much better precision this endoscope inside the airway all the way to where the lesion is. So this will be the next step. We do not have this available. It's $600,000.
Is it on a capital budget list?
No, not yet, but we're working on it. It's myself and the pulmonary team. We have Dr. Black, who's leading the group, and we have Dr. Lacey and a few other pulmonologists have been here before. Been here for a while. We have a few new younger pulmonologists. This is what every good training program exposes their fellows to right now. So it's something that we'd love to replace this with this. Advantages, you can get to really small lesions out in the periphery of the lung with much more accuracy with this system versus the old one. So the yield, the success rate in terms of getting a good sample biopsy is much higher. Something that we're looking as to future plans here is to keep things moving. To date, there is not a system, this type of system. Dartmouth has something similar, but not this brand. It's like a cousin of this, but there's no system in New Hampshire. Boston, there's a few at MGH and Brigham and so forth. So. Last time I talked about moving on and getting what we call the endobronchial valves. These are very small one-way devices, valves basically, that can be placed inside the airways. And what they do is they prevent air from moving out, moving out of the lungs. Last time when I was here, we're in the process of looking through getting internal, like institutional review board, and you have to go through the committee and whatnot. So we were able to get all that done, and we're ready to go. So we're approved to use them. What we'll use them here for would be for patients who have terrible lung disease, have large areas of destroyed lung tissue, who collapse their lung because of emphysema and because of large bullous disease, and who fail any other treatments, any other attempts to keep their lung expanded and heal these major air leaks that they have. So those would be the patients. They're not that many, but since I've been here, there's at least a half a dozen, if not more, that would have benefited from this. So if you have a big air leak, a big hole in the lung because of the terrible lung disease, you're able to, and everything else failed, and you cannot take them to the OR because they're physiological, they would not tolerate surgery. You place one or two or as many as you need of this one-way valves. You basically you're excluding that segment of the lung that's leaking from the system, and that's how they heal, and they can come off the ventilators and get the chest tubes out, and the lung over time heals, kind of scars down. You then come back, 6-7 weeks later and remove them. Literally go back in, and they have a little handle. Gosh, kind of like back there. No, I'm sorry, here they have a little handle. You go and grab that handle and you remove them. You don't leave them in forever. But they do work, and they help basically stopping large air leaks in the lung. So since last time we met, finally I was able to go through all the committees, all the meetings, in person and Zoom, and we can proceed to. So not yet any patients yet, but I'm sure they will come. I mean, we had them in the past, and they will come. Questions? The other thing that since last time we met, I said I would like to go ahead and have here, it's nothing new. I mean, endobronchial stents inside the airways, inside the esophagus for various tumors. Nothing new. They've been around for many, many years. For whatever reasons, we're not doing them here, but since I'm familiar with the technique, and then the pulmonary team also were able to now, we have all that we need, and we can proceed. Patients that, like the patient I saw with the laser, imagine if they were to have a cancer here, you do that laser therapy, you open them up some, but then you have to keep that space open over time, preventing the tumor from getting back in there. You would place this stent. It's a metal stent. They're usually covered with plastic, so the tumor cannot grow through the network there. And you're able to put them in and keep the airways in this case, or esophagus open, so air or food moves through. So since last time we met, yes, we can do them right now, and we're moving forward with this. The other thing I talked last time, and since then we did a few cases of this. It's patients with rib fractures from. It's New England. If it's not skiing in winter, is mountain biking or horseback riding, as you know. Actually, a patient a few, but one that comes to memory now is a lady who has horses, went on a horseback ride, the usual. It's afternoon. I didn't have my helmet on. I didn't have my vest on. I knew the horse. I knew the trail, and she fell, of course, and had a bunch of broken ribs. Now, in the past, the way we would fix them would be with big incisions on the side and getting to the chest wall and putting metal plates from the side, if you would, from the outside, if you would. Now we can actually place, with a VATS, place plates inside the chest, small 2 holes on the inside, if you will, of the ribs, and then you come in with some lug nuts and bolts and stuff like that, and then you fix the plate from the inside in the chest, so the fracture would be here. It's much faster. It's fewer holes to the ribs. With a classic technique you used to have. So imagine this plate would be up here on the surface, so you would have to put at least 3 screws on each side of the fracture, so at least 6 holes. Drill at least 6 holes in a rib. Much longer operation. This is much faster, and the reduction when it's fractured, because you come in with a plate from the inside and you get the ribs together, get the fracture together, you get a much better reduction of the fracture, which means less pain and much faster healing. This is a picture of how this is kind of done in the OR. Doesn't project very well. There's one small incision that you move around to catch a bunch of ribs, and this is how you place the plates inside. And this is kind of how it looks inside. This is a camera is inside the chest. This is the inside of the chest ribs from the inside. This is one plate, one metal plate. It's used 2 wires to kind of guide it through the holes onto the chest wall, and then you come in with the screws in there, and you fix it to the chest wall. And this is the end result with a bunch of ribs that are secure from the inside. Much better. I'm sorry if it's too graphic for you. But it's much faster, and you get a much better reduction of the fractures, and patients do very well. So we have been doing this here, and I think it's us and the Elliott who offers this. I don't think that Dartmouth does it. So no, you bought them. They're yours. You do not. You do not have to take them. It's between you and your insurance company. No, you do not. They stay in forever. They are made of titanium. It's like inert material. They don't. So far, as far as we know, they don't create any inflammation. They don't. Rarely so far that I've heard that. My question when I looked at this technique was, well, how many of this did you have to take out? Do you get infected? Do they fracture? So far, the answer is no. None of them that they've been put in that were infected or if you come think of it, they are inside the chest. So the ones that were on the outside, you had the skin that you have to close over, but you already had sort of created a passage between the outside wall and where the plates are. So depending on how that healed, the chance of those plates, the old ones, to get infected is much higher than this. These are placed on the inside. They're kind of protected. They were never sort of exposed to a direct trajectory to the outside wall. So maybe that's why they don't get infected that we know so far. But again, I like it. I like it better than the old technique. Not all the patients. There are some patients that you still have to do. Actually, the lady that I did, she had she had 3 ribs done like this, but another rib that was fractured because it was not her first fall of a horse. It was one rib was refractured this time, but because it was fractured before, it was deformed. So this plates were not malleable enough to kind of mold to the contour of the deformed rib. So I had to basically mold manually a plate on the outside. So she had a combination of both techniques, but she did well. Go ahead.
For someone such as that, who might fall off their horse again,
The what?
do you think that would add strength?
Well, I mean, okay, this is.
People who are have them just prophylactic.
This is, no, this is kind of like on the lines of patients who smoke and have surgery for lung cancer and they stop smoking. She went with experience, it was less painful than the big open, procedures in the past. But majority of these patients, they realize, so she's more cautious now. Can she fall off the horse again? Absolutely. Actually, we had a patient who we worked on one side, and then I was away, and the office called and said, "Hey, he's back in the ER." And Tana and I was like, "Okay, what side is it?" Because he only has a warranty on this side for me. He doesn't have a warranty for the other side. He said, "No, it's the left side. It's the other side." Oh, okay, so it's not the side that I worked on. So yeah, I mean it's. But I don't know whether if she were to fall off the horse now on the same side as she, whether she's protected. I don't know. But I'm hoping that she's more cautious now after this experience in hospital stay and so forth. So we'll see. Other things that we're working on here, we do have a lung cancer screening program that now it's run through your primary care physicians, and I strongly, and these are the criteria to qualify for it, and I strongly suggest you get in touch with your primary care physician. It is a great program. It was a much better program until, as kind of usually happens, CMS and the government got involved. They made it now that the primary care, the primary care physician now has to have a meeting with you and establish all these criteria and whatnot in order to order CAT scans and whatnot. So they're going to be more onerous if you would on the primary care physician. They're busy. They're busy with diabetes. They're busy with colonoscopies. They're busy with other calls. So actually we saw a decrease. So when the program started, it was much easier to get in. Like anybody could order a lung cancer screening. Like you come in and you come to us, for example, you will say, "Oh, you fit the criteria, let's order a lung cancer screening CAT scan for you," which is a low-dose CT. Now we cannot do that. So we saw actually nationwide a decrease in the number of patients who were enrolled in lung cancer screening after they made it such that the primary care physician has to be involved with it because they're busier. But if you fit the criteria, you definitely suggest to get in touch with. You will get a low-dose CAT scan chest, and then you'll have to get one every year for a few years, as long as they are normal. So if you get one and it's normal, doesn't mean you're done. It means you have to get it, every year to make sure nothing else pops up. Also, we do have a very, very good smoking cessation clinic. It's run by and with Dr. Mayer from vascular surgery in our vascular surgery clinic, which geographically it's the same space as us. We are together with interventional radiology, vascular surgery, cardiology all together in the Memorial West. It's a great clinic. It's a great program. It's one-on-one visits with a provider, whether it's Dr. Meyer or one of his nurse practitioners. So I tell my patients that it's not one of those, group shaming, sessions that don't work. They meet one-on-one. They come up with a plan. They follow up, and as you can imagine, a lot of my patients are smokers, and I refer them to, and they got very good, good feedback and good results. So it works very well. So. I did start a clinic in Laconia. I think I mentioned this last time when I was in April of last year. It's going very well. I have we have very good feedback from patients. As you know, a lot of our patients come from what's called up north. To me, everything is up north. They prefer to stop in Laconia versus traveling another 50 miles or 30 miles, whatever it is, to here. So it's a very busy clinic, and the patients love it. I don't see patients in the hospital there, just the clinic, but it's good. They appreciate stopping there versus coming down here. And the last thing that's new, that again, since last time we met, it's been now up and running and doing very well. It's the incidental lung nodule program. Basically, what this is a safety net looking for patients that come into the majority in the ER or the hospital service. They get admitted to the hospital and get an imaging study, a CAT scan or chest X-ray or whatnot, that it's unrelated. It's done for a different reason, but on that exam, a incidental finding of a lung abnormality is seen. Usually, in the past, these patients will get a notification. It'll be like, hey, by the way, something was found in a CAT scan. Make sure you get in touch with your primary care physician. He or she will follow up with you about this. A lot of these patients, unfortunately, especially the ones who we see through the ER here, they do not have a primary care physician. The ER here downstairs is their primary care physician, and those patients would be lost then to follow up, and they will show up a year later with a lung cancer that's beyond anything that you can do in terms of cure. So what we're doing is we're looking at, as I said, through radiology, imaging studies that see this, they have all these incidental findings. We review them, and then we get in touch either with the patient or with the primary care physician or with the ordering physician to alert them that there is something going on there, and to see whether we offer them the option of either having this taken care of on their own through their primary care physician if they have one or whatnot, or to come and have this done through our system. And when I say through our system, it's truly a multidisciplinary clinic that I involved with. They got involved, that I created with myself. It's a pulmonary medicine doctors, the radiologist, and we meet every other Thursday at the end of our tumor board and review findings from reports that we get from radiology on a twice a month. We get a stack of reports from radiology that flag, abnormal findings. And since we started looking, I think it was August of last year, the program started, and since then we have at least one patient that was found to have he had a CAT scan of his shoulder for issue with the shoulder. On that CAT scan of the shoulder, they caught part of his lung. It was noted that on the report there's something in the lung, but again, the person who ordered a CAT scan was concerned about the shoulder. That kind of fell through, but we picked it up, and sure enough, it was a lung cancer, and he had surgery, and he did well. So if it's just one case since August of last year, in my book is a victory. There's a few other elderly patients who most likely there were lesions that probably were lung cancers, but because of advanced age, they chose to do nothing. But so it works very well, and it's moving along. It's a lot of engagement and work from myself, the pulmonary team, our staff in the office, getting in touch with primary care physicians and patients themselves. But it works great. And I think that's all I had.
Thank you.
Thank you.